Good morning, everyone, and welcome to the Network of the National Library of Medicine 2021 Virtual Symposium, Responding to the COVID Infodemic. I'm Kathy Burrows, Executive Director of the Pacific Northwest region of the NNLM based at the University of Washington. On behalf of the Planning Committee, I want to say we're so glad to have you with us as we hear from an incredible lineup of presenters and panelists. During this two-day event, the discussions will help us understand how the COVID epidemic has disproportionately affected marginalized communities and how organizations throughout the network of the National Library of Medicine have been responding. You will come away with insights, ideas, and guidance for effective outreach and education to address misinformation and mistrust. And now, before we start, I have a few housekeeping items to cover. First, this session is being recorded. During all sessions, we have everyone muted to cut down on background noise. If you would like to make a comment or ask a question, please use the chat box and send it to everyone so the person monitoring chat doesn't miss it. We're running on a tight schedule, so we'll end on time so everyone can get to the next session. All sessions are eligible for CE credit from the Medical Library Association, and several sessions are also eligible for the Certified Health Education Specialist credit. We'll be sending out an evaluation at the end of each day. Completing the evaluation is the first step in claiming your CE. And I'm very excited to get us started and so honored to introduce our first keynote, Dr. Vin Gupta. Dr. Gupta is an affiliate assistant professor of health metrics sciences at the Institute for Health Metrics and Evaluation at the University of Washington. Clinically active as a pulmonary critical care physician, Dr. Gupta's research has focused on several important issues in global public health. He concurrently holds an active commissioning as Major in the United States Air Force Reserve Medical Corps, where he serves as a deployable critical care physician. In his current role as principal scientist at Amazon, Dr. Gupta provides clinical and strategic leadership to the company's internal and external COVID-19 response work, including overseeing the funding of clinical trials, expanding its work in public health through community-based initiatives, and ensuring the implementation of evidence-based workplace health and safety protocols. Dr. Gupta received his BA from Princeton, his MD from Columbia University, his master's in international relations from the University of Cambridge, and his master's in public administration from the Kennedy School of Government at Harvard. He is a term member of the Council on Foreign Relations, a regular health policy contributor for national media outlets, and a board member on several health-focused nonprofit organizations nationwide. And now Dr. Gupta will give his talk, The COVID-19 Pandemic, the Crisis of Communication in a Pan-Infodemic. He welcomes questions, so again, if you would like to make a comment or ask a question, please do use the chat box and select everyone when you send it. So Dr. Gupta, we're delighted to have you with us, and I'll hand it over to you now.
Kathy, thank you. And it's such a pleasure to be here amongst all of you leaders in scholarship and in educating all of us to the network of the National Library of Medicine. So thank you again for the invitation and to speak on this important topic. I do want to be mindful of the fact that we have 55 minutes, and I do want to make as much room for questions as there may be interest in asking questions. So I'll try to keep my commentary to about 35 to 40 minutes at most. This is what I'd like to focus in on in the time we have together. First, leveraging data and visualizations from the Institute for Health Metrics and Evaluation, where I'm a faculty member, go into a bit on the current state of the pandemic. So what does the data show us? And then a bit on what are we actually forecasting, the timeline towards normalcy. What is that forecast look like? When can we expect to achieve it? And what's the data tell us so we can start planning our lives? And does it look different here in the United States and than say in global locations across the world? The answer to that is yes, but I'll go into that in just a bit. And then lastly, and I think more pertinent to the nature of this talk, strategies, as I call it here, strategies for sanity, but just considerations for how you can really hopefully cut through some of the noise and the miscommunication, the infodemic that we live in right now in the midst of a pandemic. What works, what doesn't. I reckon I'm trying to fit in as much as I can in a consolidated piece of time. So I'm going to be sharing a lot of clips from social media that I hope drive home some of the major points that I'm seeking to make here, and strategies that I've leaned in on to get the message out on important topics. So with that, I wanted to start off by just giving us a intel brief, so to speak, on the current state of the pandemic. And so I'll be spending the next few slides just talking about where we are right now. And this is where we are. I think it's just in the United States, COVID-19 remains the leading cause of death week over week. And that's been the reality that we've been living in for at least the last 3 months. In some cases, the numbers are just so horrifying that we've gotten numb to it. But there were weeks in January where we were losing between 25,000 and up to nearly 30,000 Americans just in a week. And we got numb to it. And right now we're losing about 14,000 Americans per week. Yesterday, the New York Times, if you just go to their tracker, they tallied about 2,300 deaths. And granted, there was some data lag. So there's always imperfections in the data. But when you zoom out, this is still the leading cause of death in our country, far outpacing common killers that we're well aware of. Ischemic heart disease, otherwise known as just heart disease because of bad diet or smoking, you name it. Lung cancer, cancers of our airways, the trachea and the bronchus, those are common killers, both here and globally. And COVID-19 is well outpacing them. And I worry that this has gotten lost on many of us. I sometimes daydream about vacations and not wearing masks, hopefully in the near future, but and going out for dinners, things that I think a lot of us lean on for restoration. And it's tough. And I think that message has been particularly lost on governors in some of our states scattering the southern United States. But this is the reality here. And I wanted to start off by saying that we need to really emphasize that and message on that as strongly as possible. I wanted to talk a bit about this concept of excess mortality. It got some tread back in August, September during the presidential debates, but I don't think it really landed in the public debate on COVID, and just exactly how large the impact of this pandemic has been from just a death and disability standpoint. Of course, you go to CNN or NBC, you're going to see the daily tracker of cases and potentially even the death toll. But that actually obscures the fact that we've lost a lot more people indirectly or directly because of this virus, because of this pandemic, than we're accounting for formally in terms of actual numbers. The numbers say we've lost about 560,000 Americans, or so we think that's the total, because of severe COVID-19 infection, likely pneumonia, severe lung disease that requires life support, requires us to stay in the ICU, and then ultimately it can be a mortal event. That's how we commonly conceive of mortality and death from this pandemic. But there's indirect reasons why people are dying. They're having delayed diagnosis of other killers like lung disease or heart disease. They're staying at home and they're having a heart attack. That is actually that's a measure of excess mortality from COVID-19. That is actually a death attributable to this pandemic that would otherwise not have happened if we weren't living in a pandemic. So that's this concept, again, of excess mortality. What's the level of death we would be seeing week over week in this country if we weren't living in a pandemic? What's the actual level of death? Whether it's from heart disease, from lung cancer, from breast cancer, or from COVID-19 directly. And that difference in total number of deaths we're experiencing, say today, April 8th, 2021 versus April 8th, 2019, That's excess mortality. And this is the ratio. This is a global map that's showing the actual ratio of the deaths that we're experiencing day over day, trailing averages, say over the last 7 days versus what we saw 2 years ago, exact same time period. And so you're seeing in the United States, excess mortality rates, and depending on the state, we're doubling or tripling of the death rate relative to what we saw 2 years ago when we're not in the pandemic. That's a lot larger death toll, morbidity from this pandemic than we're actually measuring in terms of what's the daily death count from people who are dying from severe COVID-19 pneumonia. You go to Africa, parts of Asia, the Northeast especially, you're seeing that excess mortality. Those figures are enormous, 7 times the increase in deaths that are being seen day over day relative to what we saw back in 2019 on the exact same day. So the purpose of this, and this is a different look at it, is the reported number of COVID-19 deaths. That's the numbers that you're typically seeing shared in mainstream media. Here again in the United States, we're approaching about 600,000 deaths, we think, by July 1st. That's in the aqua blue bars, and can be reflected here in the high income category. But that underreported deaths due to COVID-19, direct or indirect, either because people decide not to seek care for a chronic condition, that's an indirect death as a result of this pandemic, or direct death as a result of this pandemic that's being underreported, is people dying at home because they couldn't make it to a hospital, or because they'd rather stay at home. We do know that that was a big issue, especially in parts of New York State early on in the pandemic. But this just gives you a sense that the true toll of this virus is certainly larger than I think we're measuring in our daily metrics. This is going back a little bit to just current intel. I think this and the next slide really struck me as important to talk about. This is the estimated percent of the population at the state level infected with this virus at some point over the last 14 months. And so you'll see here, sitting in Washington State, that number is about less than 10%. In New York State, it exceeds 30%. And so why is this important? Well, one, when we talk about the infodemic, and especially when we're talking about wanting to get our population vaccinated as quickly as possible, one of the biggest reasons why I hear people say, hey, doc, I don't need the vaccine, is because of this slide. A lot of people think that prior infection with COVID-19 has given them protective antibodies and that they do not need the vaccine. Well, why should I get the vaccine? I already have antibodies. Why put myself up to these rare side effects that I think have gotten outsized attention relative to their frequency? And then the second consequence of this slide is, for those that recognize that they still need to get the vaccine, even if they survived an initial bout with this virus, there is more data suggesting that you only need 1 dose of, say, the Pfizer or the Moderna vaccine. If you're in line for that 2-dose regimen, perhaps you just need 1 dose, not 2, to get protective levels of antibodies that would reassure us that you'll be protected from severe consequences if you were exposed again to this virus sometime in the future. And that's important because, as we're seeing, there are hot zones popping up again across the United States, in Michigan and Illinois, parts of Minnesota. And there's talk now about redirecting still scarce supply of vaccine from places that have enough to places that might need more to prevent these surges in hospitals that you're seeing, especially in places like Michigan. This slide would allow that to be done safely, if that makes sense. That if we truly believe that you only need 1 shot if you've had a prior infection with COVID-19, that opens up a lot of supply that currently is being constrained and being saved for those individuals, whether you've had the virus or not, to get the full 2-dose regimen. So there's a lot of implications to just one heat map here. One, that this is a reason why people are hesitant or not willing to get the vaccine necessarily. And 2, maybe this can actually help loosen or allow for more supply to go to places that really need it right now, if people who've previously been infected only need 1 dose. And this is what I was getting at on the prior slide, which is, what's the state of vaccine confidence? Said another way, what's the well, what are degrees of hesitancy or skepticism about wanting to receive the vaccine right now? So the inverse of this map. And so this is the proportion of adults open to receiving the vaccine. Data that's been accrued by publicly available surveys. Actually, Facebook has been a major driver of collecting this information, just given how many people use its platform. And it's pretty striking, again, just that there is a coastal bias. It's almost like the Electoral College in some ways on who is willing to, adults that are eligible, who's willing to receive the vaccine versus who's perhaps wanting to wait and see, or who's not reachable, who just will not receive it. It definitely appears to be less uptake or less willingness, initially at least, to receive the vaccine in the heartland, in the Southeast. And certainly we don't see that as much in the Northeast and in the West Coast. And so I think this is what we're seeing also being reported in mainstream media, which is that those that are on the center right that tend to make up perhaps the demographics of these states from a political standpoint tend to be the ones now that are most hesitant about receiving the vaccine. So certainly work to do. Forecasting time to herd immunity. So this is a huge part of what I focus in on in my academic roles at IHME, and then when I am in media or when I'm talking about the virus and the state of the pandemic, I really try to key in on these next few slides here. And so this is what we're thinking will happen based on existing supply chain availability of vaccine. So whether it's Johnson & Johnson, Pfizer, Moderna, maybe AstraZeneca, although gosh, that seems like that's a Pandora's box every day of problems. Just let's focus on the three that we have currently approved. We think we'll have enough supply by May to immunize every adult that wants to receive the vaccine by, we'll have that supply actually in hand by the beginning of May. There's a difference between being eligible and having supply versus actually getting access. And so that's the access is going to be the rate limiting step here. And so we think that hopefully by the end of June 2021, at least 75% of the adult population, 175 million, thereabouts of Americans will have received their full regimen of the vaccine, that they will hopefully not only have received it, but be fully immunized by that time period. And then there's various scenarios here where we are actually at this moment, the green line here, the solid green line and the solid sort of dark green line are intersecting. And which is a good thing. The reference rollout was going to be a more conservative forecast, so about 2.5 million doses going into arms a day. It was what we were predicting initially back a few weeks ago. And now it's essentially intersected with a rapid rollout scenario where we're hitting 4 million doses a day in those arms. So that's a really good thing. Actually, what we expect to happen, the reference scenario lines up really nicely with the rapid rollout scenario. That's what we all want. And this is why it's important. And this is going to be me segueing into strategies to combat the infodemic shortly. But this is what I think keeps a lot of us up at night in public health when we're thinking about the state of this pandemic, both here in the United States and then globally. So if you look here at the green line again is the reference scenario. That's what we expect to happen with daily deaths here in the United States leading into July 1st of this year. We expect daily deaths to come to a point that there'll be hopefully less than 100, ideally even lower than that, but to a point that is manageable, that hospital systems across the country will not be stressed, that the risk that there will be enough surge capacity in place that we can start to open up. And even if we get it wrong based on the zip code, there'll be enough hospital capacity everywhere that there will not be a surge, that we won't have to flatten the curve again, so to speak, because most people will be protected because they've received the vaccine. And the whole point of the vaccine is to keep you out of the hospital. So that's the green scenario. I won't even talk about the purple scenario because that's assuming we have 95% adoption of masks. And frankly, we've never achieved that. I believe the highest mask adoption rates that we've estimated have been achieved nationwide have been in the high 70s. So we continue to have something to aspire to there with that purple line. But the pink line, that blip up in deaths, is what concerns us all. And actually, in the most recent forecast that just went out last night, that number actually goes up to about 1,500 deaths a day in the beginning of June, then comes back down to about 1,000 a day well into July. So it's looking even worse potentially, is this worst case scenario that we think is less likely, but is possible. And it's possible because perhaps bad public policy continues to get adopted, where governors start to loosen mask mandates in more states. Certainly possible. We're seeing in a handful of populous states. No reason to think it's not possible. Where we have more Major League Baseball teams saying, let's open up for 100% capacity, following the example of certain teams in the southern United States. If those things continue to happen, it just provides more footholds for variants like the B.1.1.7 variant first identified in the United Kingdom, this double mutant variant that you might have heard a lot about that was first identified in India, to take root. And the concern here is, one, there's clearly something happening in Michigan where these variants are taking root, they're infecting younger people, and there's a parallel rise in hospitalizations, which I think is going to be the key metric here. It's not going to be daily cases anymore. It's going to be how many hospitalizations are happening in various zip codes as the key metric to drive opening, pausing, or actually perhaps regressing on any sort of reopening plan. That's going to be really key, because less people are wanting to get tested because they're getting vaccinated, behaviors are changing. And so the case rates, I think, are going to become less useful as we move ahead into the summertime. But that pink line is vital to keep in mind here, because Paris and France more broadly is locking down again. I mean, that was astonishing to all of us in public health, especially in the clinical front lines, to see that a country that 4 weeks ago we thought was actually hopefully going to make their way, even though they were lagging on vaccination, make their way through it, navigate some treacherous waters, and still be able to avoid an additional lockdown. Turns out that's not the case. Germany, again, a country with a very functional healthcare system, locking down again. Really astonishing and surprising to see that. Canada, I have a lot of colleagues. I was just on the phone on a conference call with colleagues in the Peel region in Toronto. They are in the midst of a significant surge, not only in cases but in hospitalization. Same thing in India and Brazil. So there is going to be a different reality in the United States, we hope, come July 1, than from what we're seeing in the rest of the world, but it's still going to impact us, because the more COVID-19 is given chances to change through unconstrained transmission, because vaccination is lagging in these countries, the more likelihood there is for a variant to emerge that escapes all protective antibodies, whether from natural infection or from vaccines. So we're really in a tenuous reality right now. Our progress is real, but it's fragile. I won't spend a lot of time on this, and I just monitoring the time here, because I do want to get into strategies to combat the infodemic here. But this is forecasting just what we would see in terms of daily cases through June 1st, 2021, I should say 2021, for the three scenarios I mentioned on the prior slide. Again, if we're seeing about 1,000 to 1,500 deaths a day well into the summer, we'd be seeing potentially as high as 100,000 cases a day. So that is less likely, but it's possible. And this is just to show that us at IHME are not just making things up, that there are a lot of other very credible models like those developed by our colleagues in Imperial College in London, and other very prominent institutions across the world that are basically, in most cases, forecasting exactly what we're forecasting, potentially with some differences in terms of when they expect to see deaths really decline to very low levels. But we're all, generally speaking, seeing the same thing in terms of a decline in deaths to a manageable level sometime between the months of July and September, depending on that model here in the United States specifically. I did just want to give all of you a bit of a look underneath the hood here as to what are the inputs for these models. You probably were like, well, how the heck do that every week? How do we know what are we changing here? What are the inputs here to actually say, well, deaths might be going up versus down? We have a lot of policy inputs in place. So are there primary school closures? For example, here at the top of the slide, you'll see these various policy inputs. Secondary school closures, gathering limits on the size, the density of people that can be in a place specifically. Are restaurants open? Are they closed? Indoor dining, is that open? Is it closed? Stay-at-home orders, is that present? Are there mask mandates or they're not? If there's orange here, that means there's some sort of mandate in place. Let me just make sure I'm not. So the orange actually reflects that there's no mandate. Some sort of version of aqua on the slide suggests that there is some sort of mandate in place. So at the time that we built this, which is a few weeks ago now, there was some there were still limitations on at least high schools convening. If not, in most cases, states have opened up K-8 for in-person education, which is a good thing. In some cases, this is also a good thing, there's still limitations on large crowd gatherings, especially indoors. And so we're seeing the right policies in place in most cases, but these are the inputs that we constantly adapt to make sure our forecasts reflect policy as it is week over week. Okay, now to strategies. And this is where I'm going to really lean in on my own experiences here and share just clippings from Twitter and social media to hopefully help drive home the point. In what is a virtual space here where I'm trying to fit in as much as possible, that's hopefully the strategy you find effective. And I'd love to talk more and just talk about my experiences as me shifting into sort of now talking about my role as a communicator on public platforms for NBC and MSNBC. This has been challenging. And so for all of you that are tasked as educators, as stewards of evidence and of good and of the knowledge that we all need, especially to disseminate to those that are learning, this isn't hard. Just to watch the crisis of communication that's existed and this has made what's an already terrible situation that much worse in terms of just lives lost, confusion, people's anxiety being unnecessarily exacerbated. So what I've tried to do, and this is theme one here, is really tease out the difference between messaging on scientific certainty versus messaging on what we're confident on. And I think this is no more relevant than on this discussion of vaccine efficacy versus effectiveness. I don't know about you, but I have been, so I felt maybe because we're in a virtual world, sometimes on an island here, thinking, I don't understand why, and I'm not trying to call out the New York Times, but I put this tweet out not long ago because I was really frustrated when I saw that they put out a major headline when AstraZeneca's vaccine got a lot of press a few weeks ago about their clinical trial data. They put this headline out: the U.S. study finds AstraZeneca's vaccine to be 79% effective. And when you read the article, you realize that's actually accounting for the vaccine preventing mild disease, moderate disease, and severe disease that requires hospitalization. But mild and moderate can be defined differently depending on the study, depending on the pharmaceutical company that's developing the vaccine. But in this case, it was, did you have body aches? Did you have sniffles? Were you feeling uncomfortable? Did you have a low-grade temperature? Stuff that we would never even think to want to get a vaccine to prevent. I mean, these are just everyday symptoms of living in a world that has seasons, where there are infectious diseases that can sometimes cause mild symptoms. And yet these metrics are publicized and given headline news that are of no real world useful meaning, in my view. Nobody gets a vaccine to prevent mild illness. So when you restrict the definition of effectiveness to, does it keep you out of the hospital? Does it save your life? Well, it turns out the AstraZeneca vaccine, like Johnson & Johnson, Pfizer, Moderna, is 100% effective based on the phase 3 trials. Of course, there are now exceptions. Millions of people are receiving these vaccines. So there are the occasional older individual, less than 1 in a million, who is now has some degree of vaccine breakthrough disease. So I'm not saying that this is going to bear itself out in the real world when we're talking about hundreds of millions of people getting vaccinated. There will be the exception. But based on the data that the New York Times and other media outlets had at the moment this headline was published, 79% effectiveness. Actually, they should have said it was 100% effective at preventing hospitalizations and deaths. And I'm not saying that my word is somehow the definitive word here. I recognize my place in this world. I'm not Anthony Fauci. I'm not the CDC director. But in whatever small platform I do have, and to the degree to which I do interact with people every day, they are confused by these numbers that get thrown out that actually have no clinical meaning, no real world meaning. And so that's the difference between vaccine, how we define efficacy, which is a lab-based, as an academic term, talking about, yes, well, what is the degree to which the vaccine prevents any sort of illness, to effectiveness, which is what really matters in the real world, is to keep you out of the hospital. And that, in my view, is the difference between confidence and certainty. Are we certain in all cases that AstraZeneca keeps out of the hospital, or that it prevents all types of illness? No, we're not. But does it matter to message on that? I don't think it does. I think we should message on what we're confident on, which is, man, this vaccine really keeps you out of the hospital. And that's really the whole point here. We don't want COVID to cause more deaths. We don't really care if it causes sniffles. I've really tried to lean in on messaging, and I think and sorry, I didn't even talk about the figure here, but oh, whoops, I skipped it. So this is the second slide here. I think part of messaging on confidence versus certainty is providing visuals. And because people are confused by the numbers, frankly, I get confused and wrapped around by all the numbers here. There's too many numbers that were thrown around in the public sphere versus just showing people pictures and storytelling. I think storytelling and graphics are vital to get the point across here. And I shared this again from social media because it got traction. Several million views, lots of engagements. And when I think about my work as a researcher, if I knew something got several million views, I would think that was a success. That at the end of the day, we want people to engage, and social media is, for all its pitfalls, can be powerful, especially a powerful tool for scientific communication if used properly and effectively. And I think what I've noticed here is that visuals that tell a story are helpful, because then it's less about words, it's less about you spitting opinion, it's more just about telling a story through graphics, and hopefully maybe actually leaning in on personal experiences that can enrich what that graphic is trying to convey. Same thing here. This is actually from a patient that I cared for. The prior slide was from a patient that it's from a COVID patient, somebody I didn't directly care for. This is from a patient that I actually cared for. And in the span of 6 days, this is a combination of me leaning into graphics and visuals and also into storytelling. And I asked for TV outlets, et cetera, whenever I was doing a segment on air to show this, because I think it to me, it showed a horrifying story of a young person. In this case, this was a young individual who on day 0 had the CAT scan. This is a slice of the lungs, horizontal slice of the lungs on day 0. And then a week later had basically a massive hole in their lungs develop within a week from COVID. And we talk about severe pneumonia, severe complications. I think people need to see it. They need to understand it. And you're not going to make overnight radiologists of individuals, but again, this also got traction, and most people I interact with on social media or who email me, they're not public health experts, they're not clinicians, but they get it. they can understand basic concepts and basic visuals here. And so I think I personally felt like we've underutilized this strategy, and I'm hoping that we use it more, especially to directly head-on address hesitancy. I shared this because this is a slide that my own institute, IHME, puts out there in talks like this and when we're speaking to the public. And doesn't this just convey to you how confusing the debate and the scientific and how we talk about metrics vis-a-vis these vaccines? I mean, how confusing this is. Efficacy of preventing disease. Look at the top line, the titles of the columns. Efficacy at preventing disease, efficacy at preventing infection, and then we have the obvious. These are the various different variants: B117. This is the 1351, the P1 variants. I mean, what does this mean? I have to look at this and really think about this hard to then be able to relay and interpret what this data means to the lay public. But again, going back to that New York Times headline, they're just putting out we have 70% effectiveness at preventing the type version of the virus. They had 79%, I believe, because AstraZeneca had a mix up in their trial data. But doesn't this just tell you how in the world can we possibly expect people to understand this in a concise way? It's just impossible. So I think this again has been this effort at trying to convey scientific certainty when all we should be focusing on is confidence, ideally through graphics, visualizations, and storytelling. This has been something that I've also tried to lean in on a lot, which is giving actionable advice. And so nobody wants, especially now, I don't think anybody wants to see me or my colleagues go on national TV or on NPR and just talk doom and gloom. We're all tired of that. I'm tired of hearing myself say that, much less you hearing me. I'm sure you're exhausted hearing all these negative pronouncements. And so with every crisis, I think it's especially when there's an infodemic happening, especially when the leaders that we've elected are frankly contributing to that infodemic and accelerating it. You have to not just say, well, everything's bad. I think you have to give people actionable advice. And this is just me sharing snippets of what I've tried to lean in on here, which is partnering informally with government agencies that are trying to get the word out. For example, monoclonal antibodies, and directing them to resources that might be able to help them. And then sharing back, I will share sometimes testimonials of people that have engaged with the website that may have heard me or a colleague talk about this website with respect to monoclonal antibodies, and then share with their permission, share with them, with the public, what they wrote to me and what their own experience was. Because I think, one, it shows some degree of vulnerability and hopefully the ability to connect with people, but then that advice is being listened to and taken, and that it's having meaningful impacts on people's lives. And I think that has an amplifier effect, because then people may be more likely to listen to you if you have something that's not positive to say. Then perhaps you will have built that credibility and that trust. And so I do think it's a feedback loop there. If you want them to listen to guidance, or if you want them to listen to tough or negative news, you have to give them something positive or something actionable to act on to hopefully save their life or to keep them safe. I just put this in here just to say that I think actionable advice really, and this goes across whether it's communicating confidence versus certainty on vaccine effectiveness, or when it's just giving actionable advice, just repetition is really important. But these are complicated topics. I put this in here just because whenever I have like 3 minutes on TV, I try to use every second of that. So I work with a segment producer on air, or if it's producing something that's for an organization, or you name it, for a podcast, the prep that goes into doing these segments as well as possible, as to be as informative as possible, is significant. It's making graphics, making sure that we have the right things to highlight for people, because literally we're talking about limited attention spans and trying to get key information out in sound bites. And so I think repetition is vital. Giving graphics, again, is vital. people are visual learners in general, and especially when you're talking about complicated topics, got to give visuals, got to give repetition, and really got to make things as simple as possible. This was another example of just from my own experiences here in this pandemic, and I'm mindful that we're coming up on 20 minutes here, so I'll try to wrap up the next few. The Today Show had given myself and a few colleagues of mine in the intensive care unit the opportunity to get vaccinated on air. We're some of the first healthcare workers to get vaccinated back in the middle of December. And I do think part of giving actionable advice is leading by example. And again, leveraging whatever platforms you have to be able to do that. And this is the last part of this. I will not trying to be in any way political in this call. That's not the purpose of this, but I do think it, this was what I've noticed, and maybe this is because I'm a medical expert for MSNBC, which tends to be affiliated with a certain political viewpoint, even though I try not to state a political viewpoint on air. What I've noticed here is that it has opened me up to criticism from prominent figures on the political right when I'm just simply stating basic things. And I put this out there because basically the context of this, and this is the root cause of the infodemic. I mean, this is one of the key root causes here, is just manipulating science and really making an enemy of public health experts and clinicians. And what happened here was and this was me talking on a news show the day before I got the vaccine. And all I said was that after I get the vaccine, I will continue to mask and distance and be vigilant until we've reached herd immunity, until our nation's leaders say that we don't need to engage in those practices anymore. And at that time, back in December, there was less information than there is now about the ability of the vaccine to stop transmission of the virus. We still think you still need to do all those things, be vigilant, even post-vaccination, but we're more confident now than we were a few months ago about some of the vaccines stopping transmission, in addition to protecting you from the ICU. So I said that, and Tucker Carlson and a few others took the opportunity to say that basically I was trying to control people's lives, that I didn't want to let go of whatever perception of power he thought I had, and that we were just disciples of Dr. Fauci. And again, it was drawing in on this theme that somehow those of us in public health that are messaging on the science are trying to curtail your personal freedoms. It's a distortion of this concept of personal freedom and liberty that to me is deeply concerning, because now, especially with the vaccine, you're seeing that there is a political tenor to this, that people, especially older individuals on the political right, don't want to get the vaccine because they think the process was politicized. They don't think they need it, or they think this is public health officials trying to control their life. These are the root causes of that infodemic, that this crisis of communication. And it's really some seminal people, prominent individuals who've driven this. And so I push back on that. And I think that's part of giving actionable advice, is pushing back on nonsense. But this is the key, one of the key crises of our time, is this notion, this distortion of personal freedom as somehow me telling people what to do to control their life versus you just having the personal liberty and freedom to live a long, healthy life. That's how we define personal freedom and liberty, but they're distorting that, and that's unfortunate. And I think this is the last set of slides, if I'm not mistaken here. And just, again, leaning into my own experiences in the last 14 months, both in various public forums, one of the big issues now we're also facing is, how do we convince young people to get the vaccine, or to stay vigilant until they're eligible for the vaccine, especially with scenes from spring breakers in parts of the country. And I just came back last week. I was in Arizona, in Tucson, and was caring for a very comparatively younger group of individuals in an ICU down there. And I shared my experience caring for one of them in particular here on Twitter. And, you know, again, what I found resonated here was that people needed specifics. They needed, there was some resonance about just being specific about stories. Of course, making sure you're not violating HIPAA or anybody's confidentiality, but to the extent that you can actually lean into specific stories, it can reach people emotionally. It can reach them where they are. And here, what I was trying to do is just simply say, we're all vulnerable, that this is an unpredictable virus. We don't know how it behaves, whether you're younger or older. And what I'm seeing here is in younger individuals, people can still get sick. It's hard to predict. There's no way to predict that you will be safe and healthy if you're exposed and infected with this virus, if you're 18 or if you're 80. There's just no way to predict it. Yes, you're more likely to end up in the ICU if you're 80, but you're certainly still, it's certainly still possible for you to end up in the ICU if you're 18. And that's the point here. And so enough finger wagging, let's just tell people that this is possible and try to lean into storytelling. I think that at least disarms them to a certain degree. I'm going to skip this for the time being, but this was just an example of leaning into what I thought would be helpful when it came to meeting people where they are, when it came to vaccinating educators to restart schools. And I thought that was, educators across the country are scared, and I think rightfully so. And it's really hard. I help major organizations with workplace health and safety initiatives. It is not easy to input mitigation measures like increasing ventilation or standing up rapid testing. It's a lot easier to talk about those things. It's really hard to do it well. And so this was part of that debate. How do we just open schools up and keep them open, not open and shut? And this was just my effort at trying to meet people where they were or where they are currently, which is, why don't we just try to prioritize educator vaccinations as quickly as possible? That's the quickest line, in my view, to keeping schools durably open. But that was, again, a lot easier said than done, and a lot of debate and conflict just to get that message out. And then I think lastly, yep, I'm coming up with my last two slides here. It's just from a few days ago, meeting people where they are. There's a debate here in Seattle about, do we go back to phase 2 versus do we stay in phase 3? Phase 3 is some indoor gatherings, some ability to go to restaurants, what have you. In this case, I've been advising the Mariners on what a safe reopening looks like for them. And it's always easy to say, well, in light of a slight uptick in cases or hospitalizations, let's just close it all back down. But I don't think there's appetite for that right now. And so a key piece of, at least a strategy I've tried to lean on again, has been meeting people where they are. How do we make things safe as they are right now, so that people have a mental health outlet, or they have an ability to go enjoy the ballpark if they adhere to a certain set of common sense guidelines? I think that's really vital. And then lastly, I'll say, just trying to stay hopeful. And whether it's messaging through any public medium or on social media, it's been trying to really message on the fact that there's light at the end of the tunnel, that you're not going to have to see my face and hear from me constantly, because that would be a bad thing. But that there's hope, and really trying to undergird any message with that hope. I think it's vital, because everybody has suffered to some degree in this pandemic, whoever you are, and so that to me is really helpful, or vital to do, especially in the setting of a dual crisis and info. And so with that, I've been talking a lot. I've shared with you a lot of clippings, but I wanted to tell more of a story and just lean into my experiences, and hopefully they're helpful. But if there are questions, happy to talk and answer.
Okay, Dr. Gupta, this is Rebecca. So a few questions did come in. A couple about strategies, how to talk to people. Well, so one question is, in conservative communities, I often hear the opinion that excess deaths are caused not by the pandemic, but by anti-pandemic measures such as closures and recommendations to stay at home. This is put forward as a rationale against anti-pandemic measures. How would you suggest responding to such opinions?
So, I mean, and I think I see this from Alla, if I'm saying your name correctly. I think that's a great point. And I don't think that's entirely, I think that's it's certainly a distortion of the truth. In no situation, I have not seen any lockdown advocate that people should not be getting or seeking care when they need it. But you're right that there is not. I think there's been a consequence of all lockdowns or stay-at-home orders has been that people just don't want to go to the clinic to seek routine care or diagnostic care. That's sort of been part of the consequence of any effort to keep people at home, is that people then take that literally, and really for things that they shouldn't. We don't want them to be doing that. They will still do it, which is, not going for their cancer screening or a different type of test. Part of the problem here is that we are having a healthcare system that, in my view, is changing to address the problem that you highlight. So at-home healthcare, telemedicine has exploded. CMMS has in just the 3 months from April to June of 2020, there was 80 new pieces of regulation guiding and increased access to telemedicine. And the 10 years prior to the pandemic, there was 80 total pieces of regulation. So I do think that there was an effort to meet the moment, recognizing that we were lagging in addressing people's needs in the middle of a pandemic when they needed it. And specifically, they needed more access to high quality healthcare at home, because they didn't want to go into the emergency room, and how could you blame them? But I don't think so. In my view, the answer to that is, if that's the way that people have perceived lockdowns, that we need to do a better. I would say let's acknowledge the fact then that has been a failure of effective communication. That was a misinterpretation of the lockdown. That we are still encouraging people to seek routine care. We don't want anybody to delay care for anything. That has, in some cases, I know some hospital systems actually delayed elective procedures, so that's different. But when it came to in general screening, that is not a consequence that we wanted. It's a failure of communication, and partly it's a failure of our healthcare system. So I would push back on conservative commentators who are constantly wanting to constrain access to healthcare and constrain innovation and constrain access to telemedicine. Say the only way to really deal with that in the setting of a crisis like a pandemic is to make sure that everybody has resilient, adaptable, and flexible options for healthcare, especially at home. And the funding for that is always resource constrained. And so that's the only way to really deal with it. I know there's no magic bullet here, but I think that's, in my view, that's the only way we can actually effectively deal with it, is give people options for better at-home healthcare.
Okay, so thank you for that. I have one other question here, which I think we only have time for this last one. The questioner says, engineers are talking about the airborne spread of COVID-19, but the questioner doesn't hear the same from medical doctors. Is there a way for physicians in other fields to work together on messaging to the public?
Absolutely. I do know that there have been some environmental engineers and aerosol experts that early on messaged on the fact that this was an airborne transmitted virus. Most people and a lot of clinicians, frankly, need to be reminded what that means versus droplet transmission or droplet transmitted virus with like flu. And so, yes, now more than ever, I will say that there are efforts underway to across both public sector organizations and private sector organizations to innovate in masking, recognizing that we need higher quality, more comfortable, and ideally reusable masks for everybody. And this sort of notion of, me or my colleagues going on, I'm looking at a series of masks I have next to me and trying to show people how to tie loops at the end of the 3-ply medical masks as a way to jerry-rig a higher quality mask. But that is no longer sufficient, because if you live on the West Coast of the United States, you're dealing with toxins in your lungs whenever there's wildfire season. We know now, because of the global situation with COVID, that there's going to be a risk of a respiratory pandemic that's going to be threatening us for the foreseeable future, even if we have some degree of normalcy. So we need better communication on this, just so people understand what airborne means. I think there's still a fundamental lack of lay understanding on what that actually means, number one. But then number two, how does that influence policy and investments? Better strategic national stockpile, but then also better masking. We really do need innovations in masking, and we're lagging there. We're not that much better off now than we were 16 months ago in terms of what our stockpile looks like. We have more N95 masks. But again, that supply is limited to essential frontline workers, healthcare, otherwise. We need better masks for the masses because of all the insults our lungs will face, not just the next respiratory pandemic. And yes, I'm seeing Dorothy talking about ventilation as well. I recognize I'm coming up on time, but this is what has been so frustrating to me is this, I was serving this role for Amazon and a few other organizations where we actually spend weeks trying to jerry-rig warehouses or small rooms to become better ventilated, whether through its MERS 13 filters or you name it. It's easy to say we need better ventilation. It's so much harder to do it. So you need better innovations in masking. You obviously need heightened access to vaccinations, but to say that we just need better ventilation because this is an airborne transmitted virus, it's easy to say, it's a lot harder to do.
Okay, so I think that we're going to call it quits on the questions because we all have to get to the next session. Is that all right with you, Dr. Gupta?
Of course.
Yeah.
No, I appreciate that.
All right. So I want to thank you, and Kathy may want to jump on for opening up this symposium for us. We had several hundred people here in the room. And
Yes.
Go ahead, Kathy.
Yes, Rebecca, I just wanted to say, Dr. Gupta, I just thank you so much. And it was just a really informative and inspirational talk and discussion that you gave us lots of tips and useful information. That just thank you for the thoughtful work that you put into this talk. And it was a great kickoff to our entire symposium. So thank you again. We really appreciate your time with us.
Thanks, everybody. Thank you so much.
Thank you. Bye-bye.
All right, folks, I am going to end the session and you can make your way back to the lobby. There's 2 concurrent sessions happening next, and you can go to either or both. See you on the other side.